Good afternoon, dear students. So, I hope you all had a good day and we will continue with our class. Please kindly mute your devices because it makes noise the other side. We are still with the substance use disorder and we're still with alcohol. Okay, now let's just go through these objectives. Till so far, we have discussed about the different terms. We have seen the classes, we have seen the predisposing factors, we have seen the profile of alcohol, we have seen the historical aspect of alcohol, and we have seen also yesterday the patterns of use and the pattern of abuse of alcohol. And yesterday we have few portion left from effects on the body, and then we will proceed with the class. So today, let's just review the. This we are done. This we are done. Um, let's just review effects on the body. Right now, let's go system wise. Just a review so that you catch up and you remember. Now, we have seen yesterday the effects on the body. What is the effect on the heart and blood vessels? We have seen that it increases perspiration and that it makes the skin flush, and that this is short-term effect. But in the long term, it does increase the blood pressure of a person, and it does damage the heart muscles, and in some case history, which you will see when they come as neuro cases, you will see they have history of alcohol use and abuse, and they have history of going into CVA. Okay, and sometimes some of them they may even go into MI, and they also go into sudden cardiac arrest. Why? Because of the effect it has on the heart and blood vessels. Now, on the brain, we have seen that it causes speech to be slurred, and it causes difficulty in walking in short term. In the long term, we have seen that it does damage. It does damage the brain cells. Later on, we will see what it does in today's class. In the later slides, we will see what it does to the there is Wernicke's encephalopathy and Korsakoff's syndrome or psychosis. We will see what that is all about. Okay. So in the nervous system, it damages the nerves. Thus, it results in numbness in the hands and in the feet. Now, in the liver, the short term is what it does. We have seen from yesterday the main organ that metabolize or that break down alcohol is in the liver. Right. So what does the liver do? The liver, it changes alcohol, or it breaks it down, or it metabolizes. It gets metabolized into water and carbon dioxide. And we have also seen in the class yesterday that the liver takes only 0.5 ounce to metabolize and to digest it or to convert it, right, per hour. So whatever amount of alcohol that the person drinks, the liver can only metabolize that much in an hour, so it keeps circulating in the body, thus it affects the other organs too. Now, the long term is there can be liver damage, possibly resulting in cirrhosis. But before the liver goes into cirrhosis, they go into the liver go into fatty liver. Now, so one serving of alcohol, one serving is 0.5 ounce, right? So one serving it can oxidize at least one in 1 hour. So we cannot speed it up. So until and unless it gets oxidized, it keeps circulating. So you can imagine, and you, if the person is gulping, and if the person keeps drinking, right, drink. So there is a lot of alcohol inside the body. Now, fatty liver, if the person drinks, it can be reversed. Otherwise, person go into cirrhosis, which is irreversible. Now, so these are the difference between the healthy liver and in the alcoholic liver. And we have seen yesterday also, I think this is a slide that we stopped, yes. The effect of alcohol on the stomach and on the pancreas. Sometimes, from the cases that I have seen and from the case either on on my cases that I do, or the one that we see in the hospitals, or the one that comes in OPD, we will see most of them, they come with pancreatitis. But if you take the alcohol consumption history, they do have. Some, they come with GI bleed. Okay? Some, they come with, you must have learned esophageal varices, right? You must have learned portal hypertension. It does increase all that, right? Now, especially when the stomach does not have food, so what does it do? The alcohol have more effect, and it does more harm to the stomach. So the long-term effects, it causes the irritation occurs in the mucosal lining, thus it causes open sores, therefore they end up with duodenal ulcer, they end up with peptic ulcers, some of them end up with the CA changes, okay, and the pancreas also becomes inflamed. Okay, now we will continue to see today what does it do. We have seen it does have a lot of effect on the brain, on the nerves. Now, on the nerves, when we see most of the patient, when you will take the history of the physical examination on them, you will find that they keep telling or they keep complaining that they have numbness, they have pain, burning, tingling sensation, carpal tunnel syndrome. Okay, I think you by now you know what is carpal tunnel, that prickly, pindly sensation that we feel on the hands, right? So all of this they do have. Why? Because it is believed that the alcohol disturbs the absorption of vitamin B, vitamin B. Okay, there is vitamin B deficiency in these, it's particularly the thiamine. Now, what happened here? Why does it disturb this? It says that it disturbs the breakdown of the food, and it disturbs the absorption of vitamin B, resulting in the deficiency of vitamin B. The main deficiency vitamin that we see in substance use disorder is vitamin B, thiamine. That's why when all these patients, they do get vitamin B supplement, or they are put with thiamine supplement. Okay. And this vitamin B, not only the deficiency, not only disturbs the nerves, it also disturbs up to changes up to the in the brain too. Okay, the process is reversible. Please mark here. Process is reversible once there is abstinence from alcohol. So whatever food the patient eats, it gets metabolized, the absorption gets proper, so whatever deficiency that the person has gets restored, thus this neuropathy gets restored or gets reversed. Otherwise, patient for those very chronic alcohol, remember those phrase? The very chronic alcohol where there is a lot of physical disintegration. Right, and they are mostly intoxicated rather than sober. In most of them, when you look, they are thin. It is like one plank, okay? And they have a lot of muscle wasting. I think by now you know what muscle wasting is, okay? And even paralysis can also occur. Okay, so this is peripheral neuropathy. Now, the other cause it does is alcoholic myopathy. Myopathy, okay? Now, alcoholic myopathy occur as an acute or chronic condition. Now, what happens in the acute condition, okay? In the acute condition, the individual experiences a sudden onset of muscle pain, swelling, weakness, reddish tinge in the urine caused by the myoglobulin, and a breakdown product of the muscle excreted in the urine, right? Myopathy, from the name itself, it has got to do with the muscles. Right. So you can understand, you can relate what alcoholic myopathy got to do with all this muscle wasting and all that. Okay. Now, so from where this myoglobulin takes place, that means there's a reddish tinge when the person when they do urine tests. Okay. It comes from a breakdown product of the muscle which is excreted in the urine, and a rapid rise in muscle enzyme in the blood. Okay, now muscle symptoms are usually generalized, but pain and swelling may selectively involve. Most of the time they will say they have pain in their legs. They will say, doctor, we feel that we cannot walk. Our legs are very tight, especially the calf muscle. They do complain a lot about this. Okay, now if you will recall, if you will observe when patients were talking with doctors in sun care, especially the addicts, they will always say, doctor, our hands are tingling, we feel they're tired, they're weak, and the calf muscle is tight when we walk. Okay, it is because of this. So alcoholic myopathy is thought to be a result of vitamin B deficiency. See, vitamin B, remember vitamin B, thiamine. Okay, now Wernicke's encephalopathy. In Wernicke's encephalopathy, it represents the severest form of thiamine deficiency in alcoholics. See, initially, person has neuropathy, right? Neuropathy. Then, person will have alcoholic myopathy, and then when the deficiency is too much and the alcohol, please mute your devices, student, and thank you, and the alcohol consumption continues and there is no abstinence. So what happened? The vitamin B deficiency continues, and the serious form of that is Wernicke's encephalopathy. Now, what happened here? How do you know that a person has Wernicke's encephalopathy? Okay, the symptoms are, please note these symptoms: paralysis of the ocular muscles, there is diplopia, there is ataxia, there is somnolence, and there is stupor. So if thiamine replacement is not done, that means if a person does not stop taking alcohol and we do not replace the thiamine level in the body so that it correct or it restore the deficiency, person may go, like it can go up to fatal. Okay, now cortical psychosis. This explains why person go into substance-induced psychosis. Okay? Now, cortical psychosis is identified by a syndrome of confusion. There's loss of recent memory. There is confabulation. There is a lot of confabulation. If you will recall what confabulation is all about, they fill in the gaps because those memory, it gets distorted. So they have a lot of confabulation. Now, in the US, the two disorders, most of them, they consider this as Wernicke-Korsakoff syndrome. Okay, in United States, they said these go hand in hand and they term this Korsakoff psychosis and Wernicke's encephalopathy. Because of these, person go into psychosis, and they do have psychotic symptoms. Okay, now how do you treat when the patient is gone up to this? So they give them parenteral, those which needs immediate. Okay. Start with parenteral thiamine replacement, but for some who come at an early stage, they give it oral thiamine replacement. Now, so that is about the Korsakoff psychosis and Wernicke's encephalopathy. Now let's just see. In encephalopathy, it is a serious form of thiamine. For some, they occur together. Okay, so this can be corrected only by the replacement of thiamine. Now let's go on. The other effect it has, it causes leukopenia. Now, what is leukopenia? Okay, there is the production, function, and movement of the white blood cells are impaired in chronic alcoholics. Now, who is a chronic alcoholic? If you will go back to Jelinek's phase, they are those at the last phase. Okay, the crucial, then the chronic. Remember? Phase 1 is the pre-alcoholic, second one is early alcoholic, then we have the crucial phase where a person can go this side, that side, and we have the chronic phase right now. So when a person has gone up to a stage of chronic alcoholism, so what happened? It affects the white blood cells. What does it do to the white blood cells? The production, function, and movement gets impaired. So when the white blood cells production, function, and movement gets impaired, so definitely WBC are the defense of the what we say, the army of the body, right? So the protecting the body from infection. So if this gets impaired, automatically it places the a person into a high risk of contracting infectious disease. And because they have less of the I will not say less, because they have impairment in the production, function, and movement of WBC, therefore the recovery rate and the process of recovery gets a little complicated, okay, and it affects, okay. Now, the other one, there is thrombocytopenia. In thrombocytopenia, what does it do? This is also a toxic effect of alcohol. What happens here? Here, the production of platelets and the survival of these platelets gets impaired or gets affected. So, if platelet gets impaired or the production is affected, automatically the patient platelets has got to do with clotting, right? So if there is no blood clot, what happens? It places a person's risk at for hemorrhage. Okay. Now all these will stop if a person abstains from alcohol, and there can be rapid reversal of the deficiency. Now, in leukopenia, it places the person high risk for infection. In thrombocytopenia, it places the person high risk for hemorrhage. Leukopenia has got to do with white blood cells. Thrombocytopenia has got to do with thrombus, platelet production. Okay, so remember these terms. So why I'm dealing and I'm explaining with this, because you will see a lot of these, and it is important when we give psychoeducation to these persons for them to understand. And once they understand this also is one where we can change the where we can increase or boost up the motivation for the patient for the addiction. Yeah. Now, the other one is sexual dysfunction. It does act on the libido. Now, please understand, when a person is under intoxication, the inhibition of there is a lot of sexual inhibition is not there. Inhibition is what? Inhibition is when a person is aware, right? A person is aware and he knows, and the ego, super ego is related. But when a person is intoxicated, those sexual inhibition dies off. Be it alcohol, be it drugs, be it any other substance abuse, right? Now, what happened here? Always when you will see research articles or research studies, you will find that alcohol and sex, drugs and sex always go hand in hand. Why? Do you think the person wanted to? No, it's just because under the effect of this, they have that feel-good, ecstasy, euphoric effect, where inhibition of thinking, that sexual inhibition dies off. Right? Now, when they continue to abuse, it does affect their libido. Sometimes in the female, let's see that second para. For women, it changes the menstrual cycle and a decrease or loss of ability to become pregnant. Woman. In men, what happened eventually when they go on drink, they love drinks more and all. They say, if you will recall when we were reading, when we were discussing at the initial class, when they have reached to that stage that they have to gratify what they want and they don't even care for any other thing. So it disturbs the hormone. So once the sexual hormones gets disturbed, there is a result in it results in diminished libido. Libido is what? Libido is that, that sexual want or desire or climax that a person has. Okay, there is decreased sexual performance and it leads to impaired fertility. Okay, these are the sexual dysfunction. Please do not get misunderstood between the alcohol intoxication or substance intoxication with sexual dysfunction. When a person is intoxicated, the inhibition is not there. We are talking with prolonged use. For women, it does affect the cycles, and then it will affect with the conception too. For men, it does affect the hormones, the sexual hormones, okay? And thus, it leads to diminished libido, decreased sexual performance, and it can cause impaired fertility also. That means they may be impotent for some. Some they come with impotency. Some they come that, it disturbs the sperm count. Some it disturbs the fertility rate of the sperms, right? So all these, the thing the alcohol does. Now let's see, we have talked a lot about alcohol. Now let's try to understand alcohol intoxication and alcohol withdrawal. Okay, intoxication. Intoxication is what? Alcohol intoxication. We have seen abuse, we have seen use, abuse, dependence, tolerance. Now we will see what is there in intoxication. Now, alcohol intoxication, the symptoms include disinhibition of sexual or aggressive impulses. I have explained to you. There is mood lability, there is impaired judgment, impaired social or occupational functioning. Why do they have all these? Because it disturbs their thinking. Okay, it disturbs their normal thinking process, the normal judgment, the normal perception gets disturbed, definitely. So judgment gets impaired, social and occupational function gets impaired, speech, there is slurring of speech, incoordination of the muscles, therefore they will go to unsteady gait, then they have nystagmus and they have flush face. Okay, these are the signs of alcohol intoxication. Alcohol intoxication occurs at a blood alcohol level between 100 and 200 milligram per dl. Now, to understand this intoxication, some body, they get intoxicated, they reach this intoxication stage at an earlier phase. It depends on the tolerance level. Okay, now, so intoxication usually occurs at blood alcohol level between 100 and 200 milligram per dl, and that has been reported at levels ranging from 400 to 700 milligram per dl. So when the person is intoxicated, again we see these symptoms. Disinhibition of sexual or aggressive impulses, there is mood lability, the judgment gets impaired, social and occupational function gets impaired, speech also gets affected, muscular coordination also gets affected, and when you look at them, they have flush face, they have increased perspiration, they have unsteady gait, and they have nystagmus. Okay, now withdrawal. Withdrawal, what happened? Withdrawal, intoxication is when a person drinks and a person gets intoxicated with the alcohol. Okay, what does it do? It causes this. Withdrawal from the name itself, withdrawal. That means the body is not getting that amount, that tolerant amount and that craving amount. If you will go back to the biochemical factors, what does it do? Alcohol works at the morphine effect. It calms down the person. So when a person does not get that desired amount, okay, now when will he not get? When he does not take the alcohol. Now, for how long? Because the body is so used, so within 4 to 12 hours of cessation or a reduction in heavy and prolonged alcohol use, several days or longer. Sometimes they will come. I have not touched drinks for 3 days. Okay, so those who are so used that their body is so dependent on it, even if they drink for 4 to 12 hours, withdrawal symptoms develop. For some, 3 days, for some, week, or even more. It depends from body to body. This we will know, that's why we collect the alcohol history from the person. Okay, now, how do you know that the person has alcohol withdrawal? What are the symptoms? Now let's see. The first one, coarse tremor of hands. When you ask them to do this, okay, I'm not sure whether you can see me or not, they will have this shaking. Okay, thumb. There is tremor of hands, tremor of tongue, tremor of eyelids. Okay, they will complain of nausea and vomiting. They have malice or weakness. Sometimes they have withdrawal. The person who will bring them to the hospital will say, suddenly he was taking bath or he was eating. Most of the time, in most of the cases that I have seen, he was taking bath, he was alone, and suddenly he collapsed. Okay, and then he bit his tongue or all that, right? And then he was unconscious for some time. They'll bring it. So all this, the signs is tremor of hands, tongue, eyelids, nausea, vomiting, malice or weakness. There is tachycardia. There is sweating. There is elevated blood pressure. There is anxiety, depressed mood or irritability, transient hallucinations or illusion. There is headache and insomnia. Okay, these are the symptoms which may appear. I'm not saying all the patients will have these. Most of the patients they do have. Okay, so at least the combination of this. But the main thing is now, which you will see nausea, vomiting, tremor of hands and stomach, and then that profuse sweating. Okay, and their heartbeat like that they will come. Okay, elevated, and if you check the BP, it is high. Sometimes it may, and they will complain of headache, and then they will talk all things that irrelevant talk. Irrelevant action, because they may have hallucination and illusion. Okay, so these you will see in the withdrawal patient. Now, when does it become a complicated withdrawal? Okay, when a person starts having delirium tremens. Tremens are those delirium. If you will recall the class on delirium dementia, delirium is when they have clouding of consciousness, all this, yeah. So a complicated withdrawal syndrome progress to alcohol withdrawal delirium. Now, when this one gets complicated, okay, when a person comes with this, and some they will get up to the clouding of consciousness and all that, okay, thus it becomes a complicated withdrawal. Now, when does this happen? Usually, the onset of delirium is usually on the second or third day. Okay, second or third day following cessation of or reduction in prolonged heavy alcohol use. The triad, the classical triad, please mark this. The symptoms, clouding of consciousness and confusion. Definitely, that is delirium. They will have psychotic symptoms. Mostly they have vivid hallucination and illusion affecting any sensory modality, and they will have marked tremor. Tremors are there. Okay, so, and then they have delusion, agitation, insomnia, or a sleep cycle reversal, and autonomic overactivity are usually also present. So, when a person gets complicated, okay, when he comes only with this, complication means the person start having delirium and then start speaking, start having psychotic symptoms, okay, with marked tremor. Person will have delusion, person becomes very agitated, cannot sleep, very restless, walking up and down. All these is there in the complicated withdrawal. Now, so what is the clinical presentation? Now, how do you check the withdrawal? Okay, clinically, because when a person has withdrawal, they will bring to the hospital, right? Then when you collect the history, if it is within 5 to 10 hours from the cessation of the alcohol intake, so you have minor withdrawal. When do you call it minor? Autonomic hyperactivity, tremorlessness, tachycardia, hypertension, GI upset, anxiety, insomnia, and vivid dreams. Between 5 to 10 hours, usually they have this. 12 hours, that means half a day. 72 hours. 72 hours, that means 3 days, right? Yes, 3 days. 24 in... so, 12 to 72 hours hallucination. Most of the hallucinations that we have is visual and tactile. I told you this tactile hallucination, mostly person with substance, they will feel, they will say something is crawling, tactile hallucination. Okay, then person will have seizure. They have generalized tonic-clonic seizure, about 10%. Now, and then if it goes beyond 48 to 72, then it becomes a complicated withdrawal. So they have delirium tremens, about 5%, where there is disordered consciousness. And then this is a medical emergency. They have psychotic symptoms, they have confusion, they have agitation, all that here in delirium tremens. So this is the clinical presentation of alcohol withdrawal. Now, what is the treatment then that we do if a person comes, right? Now, so if you happen to be in the ward, you must have seen when you were a second year student in the medical ward, and most of you must have seen when you were having casualty posting, right? So when a person go into alcohol withdrawal, usually they monitor the vital parameters, okay? With a special reference to blood electrolytes, fluid balance, okay, then they send for ECG. Why do they do all this? We have seen, right, what it does to the heart and to the blood vessels, right? Now, so what we have to do is, then what they usually do, they put them on benzodiazepine. Benzodiazepine are anxiolytic. Anxiolytic are those which calm the body, right? So usually they put them on any benzodiazepine, okay, but if the person is highly intoxicated, they avoid this, okay, because it is risk for respiratory depression and sedation. So they do the assessment and they give. Usually they do calm them down and they put them with lorazepam. Mostly they put them with chlordiazepoxide. This drug, okay. They put them with this. Right, and then they start multivitamin supplement, okay, and then they come, right? So usually when they come, this is what they do. Now, and then I told you, we have seen that a lot of thiamine gets depleted and there is a lot of dysfunction. So what do? They put them on vitamin D, thiamine replacement. For the prevention, we do not want the person to go into Wernicke's encephalopathy or Cortical Psychosis or the Wernicke-Korsakoff syndrome, right? And then for the hyperactivity of the for autonomic hyperactivity, they put them on beta blockers, and if any seizure is there, so they put them on valproate or carbamazepine. And if a person has psychotic symptoms, okay, substance-induced psychosis, they will definitely give them an antipsychotic. Usually, the choice of drug is HPL or haloperidol. We will learn this when we will study antipsychotics. Okay, so for hallucination, delusion, and violence in delirium, okay, they give this together with benzodiazepine. Then they do give these drugs. So this is what they give. Now, these are the treatment modalities. Right, now, what are the other services that we can do to help the person who abuse substance? Now, please listen carefully because a lot of this will come on the psychoeducation that we give and which we have to help them. So, treatment services is focused on specialized medical, psychiatric and social services. It is focused on stopping, reducing or reversing the negative health and social consequences. Remember, a lot of these persons are very conditioned. Why I'm saying conditioned? Because the body is so used, the body is conditioned to all the effects that the body gets when the person drinks the alcohol, right? So what we do, we need to again recondition them. Right, so we still use the therapy of conditioning, but our focus is on stopping, reducing, harm reduction, or reversing the negative health and social consequences. Third point, the treatment focus on preventing further health and social harms related to discontinued substance use, especially harm reduction intervention. A lot of this, it's our role, okay, as nurses, as a part of the mental health team. When we deal with a person using substance, we have to use a lot of this. Okay, now depending on the model of treatment used, the goals of treatment may include abstinence, reduce substance use, or harm reduction. Now, so first thing is, most of the patient, when they go for leaving, okay, when they go for all those treatment and all, they go into a phase of detoxification. Remember, why do they need to detox? Okay, now what happened here? They are put with most of it. Disulfiram is one of the common drug which you will get in the textbook. Okay, so a lot of alcohol is there in the body. So what we do, we need to the person needs to go into a process of detoxification. Negative aversive. Negative aversive is what? Remember when we had studied conditioning? Aversion is clubbing a positive stimuli with a negative stimuli. The effect of the negative stimuli is more than what the person wants the positive stimuli. Therefore, the person will not want the positive one anymore because of the effect. So what they do, they club the two stimulus, one that gives pleasant effect and one that does not give pleasant effect. Right? So here, after a person is well motivated, before a person goes for this, the person has to be motivated. A person has to be willing. They have to be well motivated that yes, they will not take the alcohol. Right? So to stop that, to go that, they put on this drug. Okay. Now, what does this do? It inhibits breakdown of acetaldehyde, which is toxic to the body. Okay. Now, we have seen acetaldehyde breaks down into water and carbon dioxide. Right? If this drug is there, that means person is taking this drug. Now, suppose he takes this drug, right? So if he takes this drug, this one will not allow the breakdown of the alcohol, okay, into water and carbon dioxide. So if it does not allow the breakdown, so what happened? The alcohol keeps ingested because of this drug. So it causes sweating, flushing, increase in pulse, decrease in BP, headache, nausea, vomiting, palpitation. The patient becomes dyspneic, they have tremors or weakness. It may also cause arrhythmias, MI, cardiac failure, seizure, coma, and death. So, which means that the disulfiram ethanol reaction, they call this, okay? The anti-abuse drug, the disulfiram ethanol reaction. Ethanol comes from the alcohol. Disulfiram is what we give to help with to detox the person. Right now, if a person continues to take alcohol, what does it do? If the alcohol, because of the presence of this, it stops the breakdown. So because it stops, it causes all these effects, and because of all these effects, now a patient will not want all this. Thus, it helps them to stay and abstain. Right now, the other one which they give is naltrexone. Okay, now this one, it increases the abstinence and reduce alcohol craving. The other drug, okay, deterrent agent, they call these. It increases the abstinence and reduce alcohol craving in combination with comprehensive treatment plan. It may cause liver toxicity at high doses, but it is contraindicated for patients who abuse narcotics within 7 to 10 days. Right, that means you stay away, you are well motivated, and then this help it increase it reduces the craving. Thus, it increases the ability for the person to abstain. Now, The other one which they give, the other drugs are a composite, which reduce craving, maintain the abstinence, and regulation of the glutamic system. Another one, again, naltrexone, I have told you, reducing craving, and it maintains the abstinence. It blocks the opioid receptors. And then the other one they give, lamotrigine, it decreases the amount of alcohol intake, and so this is given in combination. Now, so for a person to be able to abstain, okay, now you have to understand one thing about substance use disorder. Do they have craving? Yes. Do they know that what effect it does in the body? Yes. But why they cannot stay away? Because of the reward pathway that the body is used to getting. That is the reward, the condition, a two condition, they want it. That's why most of them they know, but then they cannot give up because that feeling that they want. So before we help them, when we help them to stop, to go for de-addiction and to maintain the de-addiction, to maintain the abstinence, motivational enhancement therapy is one of the latest and upcoming and the most therapy, the most specialized therapy that the alcoholics and the addicts they need. Now, what is motivational enhancement therapy? From the word itself, motivational. That means we need to make the person stay motivated. Okay, enhancement means we keep increasing. We keep giving generous dose of motivational allowances. We keep giving generous dose of increment. That means the mind and the willpower and the motivational power of the patient should always be at the optimum level, that they stay away, that they can handle their craving, that they can continue to stay without taking alcohol. Right, so what all is there in this MET? They call it MET. Okay, so in motivational enhancement therapy or MET, we have, but what do they do in this therapy? Inspiring motivation to change, preparing clients to enter the treatment. What treatment? Treatment is that detoxification. You understand? Because if they go for detox, if they go for detox, they will give them a disulfiram or anti-abuse. But if they continue to take the alcohol, it's no point. Unnecessary, there will be reaction, disulfiram ethanol reaction, and thus they will call all those increase in BP, flushing, all that. Okay, pulse, tachycardia, all that it will cause, right? All the unpleasant changes may take place. So we need to prepare the client before they go for all that. And engaging and retaining clients in treatment. Once they have entered for de-addiction therapy or treatment, they need to be engaged and they need to retain. After this, I'll just stop with, I think, 2 more slides. I can go, then we will stop. Okay, increasing participation and involvement. Just remember sun care, but all they do, right? We engage in the for a client to stay motivated. We retain the client in the treatment that we give them. Okay, then we increase the participation and we make the patient more involved, right? And then we make them participate more. That will boost up their self-esteem. That will boost up their motivation. Okay, then we improve the treatment outcome, and there is encouraging a rapid return to treatment if symptoms occur. Will they slip? Yes, they will slip. Will they fall? Yes. Even if they have abstained for so long, there is always a possibility that every time, even when they have abstained, when they have complete their de-addiction therapy, those 90 days, all that, right? So they need any minute, any day they can slip. So we encourage to come back to the treatment. It does not matter. They should not stay when they slip. So all these comes under motivational enhancement therapy. Now, let's see what all is there. There are 5, the basic principles of MET is express empathy. We empathize. We don't sympathize the addict, we empathize them. Why do we empathize? Because we have seen the predisposing factors, right? It can be biological in nature, it can be the psychological makeup of a person, or it can be the social-cultural makeup of a person, or it can be a combination of them. So there can be so many factors that lead the person to abuse, right? And to be dependent and to experience all these effects. So we express empathy, we develop discrepancy. Okay, there's discrepancy. Okay, avoid argumentation. That means we don't argue with them. There's no point arguing with them. As we have seen, they are always right. And they have a lot of justification, a lot of rationalization, and whatever they do means addicts are never wrong. Okay, but we avoid argument with them, and we roll with resistance. There will be a lot of arguing. They will interrupt in between. They will ask so much, and then they will deny, a lot of denial, and then some of things they will ignore. But all these will be resisting with the amity that we give. But we roll on and we continue. Okay, and we support self-efficacy. What is self-efficacy? Self-efficacy is that ability of a person to, to be self-sufficient, to be self-resilient, to be self-determined. Right, that means more of it has to come from there. So we support that. So the five principle 1, we express empathy. Principle 2, develop discrepancy. Principle 3, basic principles. Okay, the third one, avoid argumentation. The fourth one, there'll be a lot of resistance throughout. What all will there? There'll be a lot of arguing, there'll be a lot of interruption. Patient will deny so many things, and then a lot of ignoring we have to do. And then the last principle is support self-efficacy. Okay, now, so I told you, why is it important for the patient to stay motivated? Okay, here. Okay, to stay motivation, here is where they enter. Okay, when they are motivated, they said yes, they want to give up. That means they have been thinking a lot. That's why they come and they said they want to be enrolled in the de-addiction treatment. Okay, so they are here in the pre-contemplation. Then after that they go to the contemplation, pre-contemplation, before, right? Contemplation, they're already thinking, yes, you will do. I am determined. I will go this. Do you want to do this? Yes. Are you willing to stay away from alcohol? Yes. Do you understand that this is this? Yes. Everything is yes, 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 because yes. Okay, they have that. Now, then they go to the determination stage. Okay, pre-contemplation, and they are determined, yes, they will come and they will be admitted. Right, that's why they have a 90 days stay, they have a 100 days stay, they have a 120 days stay, right, when they come to Sankhya. Now, every step you will see, there is exit here, there is exit here, there is exit anything, they will go to relapse. Here also they can relapse, here also they can relapse, here also they can relapse, here also any stage. That's why we always have to keep them well motivated, right? So they first thing, they contemplate, then determine there is one exit here, then they go through the de-addiction phase and the process, then they are able, and then comes the maintenance. Here also, the minute they go out, 1-2 days, they cannot maintain. Again, they come back, right? Some they can maintain, some they cannot maintain, and they keep relapsing, right? That's why motivation enhancement therapy needs to be boosted up. They need a generous dose of motivation, generous dose of allowances of motivation, encouragement, all that, okay? The empathy, these. Generous dose of all these, right? So that a person stays strong, a person stays motivated, and relapse prevention, a person going back into abuse or use can be prevented. Now, how do we do that? We will discuss in the next class. Okay, thank you, students. I will stop here. There will be a next teacher. So thank you so much.